You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 30th, 2020. This week, COVID, the Remdesivir approval, the athletic heart in COVID, troponin silliness, and a potential new MRA drug. First, a COVID update. It is worse. Cases are increasing in Europe and in the U.S. I wrote a blog post in March that this virus would not be contained, that is, outside of island nations. I was right. Testing and contact tracing in a rambunctious and free country such as America is utter folly. 2 facts. This is a coronavirus. These are the viruses that cause colds. They are super infectious. Also making it impossible to stop is that the majority of people who get infected don't get that sick. One quick comment before I go on to the science. While I don't have a degree in public health, I am pretty sure that the practice of public health is about more than counting virus cases and hospitalization. The pandemic's effects on society are heterogeneous. It seems to me, then, so ought the interventions be heterogeneous. For instance, I stand in awe of the stupidity of our city's policy of having public schools closed while the private schools are open. I mean, since education is literally one of the most important determinants of health, this policy simply exacerbates the injustices. Whenever I discuss treatment plans with patients, we always hit on the risk of treatment and the risk of no treatment. Okay, COVID science as a lesson in evidence translation. Let's talk about the FDA decision to approve the antiviral drug Remdesivir. Now, I'm no fan of a lax FDA. The decision on Watchman was horrific. And my friend Vinay Prasad talks often about cancer drugs that get approved on terrible evidence, cost oodles, and may extend life weeks to months or not at all. So with that as a prior, I was very surprised to witness the Remdesivir nihilism and sharp criticism of the FDA's decision to approve this drug. There were some pretty big names that were criticizing the FDA. But here's the thing. I agree with the FDA's decision, and let me tell you why. First, this is an antiviral drug. It has biologic plausibility. It has known antiviral activity. Second, far more important, the ACTT trial, which is a U.S. trial. This is a well-done, NIH-sponsored, double-blind, placebo-controlled trial that met its primary endpoint. Remdesivir decreased hospital stay by 5 days. Come on, that is not nothing. Then there was the effect size on mortality. 59 patients of 541, 11% died on Remdesivir. 77 patients of 521, or 15%, died on placebo. So in a trial of about 500 patients per arm, the drug saved 18 lives. The absolute risk reduction is a massive 3.8%. Now, the point estimate of the hazard ratio is 0.73, and that ranged at as good as a 48% reduction in death versus a 3% increase. So it didn't technically meet statistical significance. Now, on Twitter, Dr. Sanjay Kaul said, if one considers a 10% relative risk reduction or a 1.5% absolute risk reduction to be a clinically relevant finding, then these data suggest an 89% probability of the risk reduction in death. That's not bad. Now, using the null mortality rate in the Lancet study by Wang et al., which was published at about the same time as the ACTT was announced. Now, if you use those negative priors, the probability of a 10% relative risk reduction is still 82%. Now, third point here. The WHO-sponsored Solidarity trial, which is published only in preprint form, had 2,750 patients allocated to Remdesivir. So that's a lot bigger trial. But this trial was carried out in 405 hospitals in 30 countries. And of course, the data complicates the matter a bit. In the Solidarity trial, Remdesivir had a 5% reduction in mortality. The rate ratio of 0.95, but the confidence intervals were all over the place, and this was clearly not a statistically significant finding. Also, Solidarity did not find that Remdesivir had any reduction in hospital stays. But Solidarity was a different trial, wasn't it? It had more patients, but it did not have a placebo arm. Instead, it was compared against the standard of care. Also, it was carried out in, quote, vastly different countries around the world with different healthcare standards. We have to look deeper into the possibility that there may have been heterogeneous treatment effects of Remdesivir. The last figure in the Solidarity preprint paper is a meta-analysis of the Chinese paper, the Wuhan paper from Lancet, the American ACTT trial, and the WHO Solidarity trial. It's broken up by oxygen subgroups, which is of course a surrogate for how sick patients are. So both in Solidarity, ACTT, and Wuhan studies, the point estimate for mortality in patients with low-flow oxygen trends favorable for Remdesivir. If you take it together, the hazard ratio for this combined subgroup is 0.80, and the confidence intervals go from 0.63 to 1.01, so nearly significant in patients with low oxygen requirements. Now, Professor Landry from Oxford points out on Twitter that if you posit patients in the low-flow oxygen arm do better, then you have to posit Remdesivir harms those who are sicker. So that's problematic, I agree. But finally, now to the adverse effects. The Solidarity trial did not report on adverse effects. ACTT found no significant difference in adverse effects, and I really haven't read that there's any major harms related to Remdesivir. So in sum, you have a drug with minimal safety issues that probably has a modest effect. There may be a benefit if given early before serious respiratory failure. Now, at the current price, I agree that this is a low-value care, but the FDA is not charged with pricing. The FDA concerns itself with efficacy and safety. And based on the totality of the evidence that I just showed, I concur with the FDA's decision. Now, it's up to us as clinicians to use the drug wisely and regulators and healthcare systems to determine the best price of the drug. Next topic is COVID and the athletic heart. Now, sometimes academics and journals get it exactly right. This week, JAMA Cardiology published a consensus document on COVID and the heart relative to athletics. This paper was led by Dr. Jonathan Kim from Emory, and it was a group of authors reviewed what is known about the effects of the virus in athletes. Their paper is a much-needed antidote to the excesses of fear-mongering surrounding COVID myocarditis. But before I tell you about the paper, I want to first point out that there have now been 45 million cases worldwide of COVID and 9 million cases in the U.S. Many, if not most, of these new cases in the U.S. are younger, healthier people. So if you just put on your Bayesian hat, wouldn't you think that if COVID had a predilection for myocarditis, we'd be seeing a surge in heart failure cases or reports of myocarditis? We haven't. Okay, now to the paper. Part 1 of the paper reviews what is known about the effects of COVID on the heart in people with no or minimal symptoms. And the answer is that studies published early in the pandemic that have observed myocardial injury, troponin elevations, in patients with COVID included mostly older people who had comorbid conditions. The authors make the point that markers that can be used with myocardial injury, say troponin, can overlap with athletic hearts. For instance, it is well known that bouts of intense exercise can cause troponin release and cause edema and inflammation on CMR scans. Second part of the paper, insights from the recent COVID-19 CMR data. The authors criticize the Puntman et al. German paper as having included patients with comorbid conditions or ongoing COVID symptoms. This study, they write, had little applicability to athletes. They also criticized the Ohio State 26-patient study based on the fact that little is known about what is normal on the CMR scans in athletes who've recovered from any viral disease. They call for a carefully standardized CMR-based phenotypic studies of athletes with COVID that include appropriate control participants and clinically relevant outcomes. Okay, third point about the paper. In discussing the role of CMR in the diagnosis of myocarditis, the authors write that athletes with low clinical pretest probability of myocarditis and isolated CMR findings should not be presumed to have myocardial injury attributable to the virus. Fourth part, they caution against screening athletes with COVID-19 with CMR based on A, the inconsistency of CMR parameters, B, the dearth of normative CMR data. We don't know what's normal. C, the current data lacks appropriate control groups. And D, there's no current agreement on the CMR myocarditis criteria in asymptomatic healthy patients. They even cite the dangers of downstream cascades from ECG screening to show how overuse of CMR could be similar in that it could lead to iatrogenic harm from the downstream testing. Fifth, they cite clearly and candidly that no, concerns about cardiac issues in COVID-19 should not constitute a primary justification for the cancellation or postponement of sports. Sixth, regarding return to play, in high school or older young athletes, they write that in the absence of systemic symptoms or persistent cardiovascular complaints, the CV risk stratification is unnecessary after the self-isolation period. In master's-aged athletes, they write that routine return to play cardiovascular assessment is not recommended, but they add the caveat that those athletes with severe COVID or persistent symptoms or significant comorbid conditions may benefit from an assessment. Finally, the seventh part, regarding the focal LGE, late gadolinium enhancement, in the RV septum in master's-aged athletes with COVID, the authors cite the previous data that finds that LGE in the RV and septum in ultra-endurance athletes. And here's why this is important. If CMR use increases due to the fear and hype of COVID, the authors write that, quote, we anticipate that this nonspecific LGE pattern will be scrutinized as suggestive evidence of myocarditis. So you all know that I'm a critic of guideline and expert opinion documents, but here is one that is unusual in its wisdom and candid writing and calls on clinicians to master the obvious and not run off the rails. But speaking of running off the rails, now let's talk about a paper in the Journal of American College of Cardiology that sought to characterize echo abnormalities associated with myocardial injury and prognosis in patients with COVID-19. This was a paper with 55 authors from New York City and Milan that teamed up to publish a chart review study of 305 patients who had COVID and were sick enough to get echocardiograms. Now, I say that because recall that getting an echocardiogram with COVID signifies a serious selection bias due to the danger to healthcare workers. At least in our hospital, we have protocols that basically say COVID patients get tests only that are felt to be absolutely necessary. So at baseline in this study of the 305 patients, 190 had biomarker evidence of myocardial injury, troponins, and 150 did not. And then 72 of the 115 went on to develop positive biomarkers. Now here comes the main results from the 55 authors. Those patients who had positive biomarkers had a six-fold greater risk of having an echo abnormality. And these echo abnormalities could include obviously important things like LV wall motion abnormalities and impaired LV function, pericardial effusion. But it also included the dreaded, quote, diastolic dysfunction. Now, the second big finding was that all-cause mortality was about 5% in those with no myocardial injury, 21% in those with myocardial injury but no echo abnormalities, and 31% in patients with both myocardial injury and echo abnormalities. And in a multivariate model, abnormal enzymes and abnormal echo increased the risk of death nearly fourfold, which was similar to having acute kidney disease or ARDS. So my comments. Just before I recorded this podcast, I noted that the paper has been covered by 30 news organizations and tweeted by 106 accounts. Some of the 55 authors are big-name academics. So I'll start, before I say anything about this paper, I should quote Doug Altman's famous quote. He said that we need less research, better research, and research done for the right reasons. So the chart review paper comes with a celebratory editorial that includes this sentence, quote, "We congratulate the esteemed investigator group from the United States and Italy for this excellent data in the issue of the journal." So by the way, to my younger listeners, if you want to get involved in academics, ask to write editorials, or speak at meetings, you have to write sentences like that. The problem is, this paper tells us nothing very useful. First of all, as I said, it is a select group of sick patients. They had to get an echo done in the first place. Then they had troponins. Now, per the fourth universal definition, the presence of an elevated troponin means there is myocardial injury. This is not the same as myocardial infarction. The treatment of any troponin elevation not due to plaque rupture or type 1 MI is treatment of the underlying cause, which of course here is the coronavirus infection and its sequelae. And that's what's being done in all inpatients everywhere. Now, a side note on doing troponin measurements, remember, the biomarker's main use is when there is a suspected acute coronary syndrome due to plaque rupture. If that syndrome isn't suspected, then there is really no reason to order this test, because if the patient is not having a type 1 MI, which is usually pretty obvious, then the treatment of all other troponin elevations is treatment of the underlying condition. Now, as far as the outcomes in this paper, if you count patients sick enough to have echoes, and those sick enough to have troponins, and those sick enough to have echo abnormalities, that could be old or new, then is it any surprise that these are markers for increased risk of death? No. I mean, come on. You could do the same sort of study for any infectious syndrome. You could do it for post-surgical patients, those with pancreatitis, diverticulitis, atrial fib with a rapid response. Now, there are observational studies that at least attempt to have a control group, an attempt at matching these groups, but not here, just a chart review, 5 patients per author. And the main finding? Sicker patients have a higher chance of dying. Now, I mean no malice, but publications like this don't do the research enterprise any favors. The authors all will gain an improved citation index, the journal will likely garner attention, but what else is gained by this? I also worry about the enhancement of fear, especially in the COVID era. I can already see the headlines connecting heart damage with COVID. Few people will read the paper for what it is, a chart review without any context or control arm. Final topic today, briefly, is a novel drug for kidney protection that may have benefit in cardiac disease. The drug's name is finerenone. Note that it rhymes with spironolactone and eplerenone. Finerenone is a selective nonsteroidal mineralocorticoid receptor antagonist. Journalist Mitchell Zoller has a nice coverage of the Fidello DKD trial, which was published in New England and presented at Kidney Week recently. The Fidello was an RCT of about 5,700 patients with CKD and type 2 diabetes. It was finerenone versus placebo with a primary endpoint of kidney failure or death from renal causes, but it did have key secondary composite outcomes, which were cardiovascular death, MI, stroke, or heart failure. Finerenone reduced the primary outcome 3.3% in absolute terms, with a hazard ratio of 0.82 and confidence intervals that went from 0.3 to 0.93, so it was significant. Importantly for cardiologists, the drug also reduced the key CV secondary outcomes, albeit with a smaller effect size. Hyperkalemia was a little higher than the placebo group, but supposedly this drug has less hyperkalemia-producing tendencies than the other 2 MRA drugs. At AHA, in coming 2 weeks, we will hear more about the CV effects of this drug in a late-breaking trial session. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, please, if you like this podcast, it really helps to give us a rating, write a review, or tell a friend. That way others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.